Welcome to the APFCB webinar on the role of clinical laboratories in COVID-19. In this lecture, Dr. Ranjit Saha will be talking on the basic epidemiology and clinical aspect of COVID-19. Dr. Ranjit Saha is currently Assistant Professor at the Department of Clinical Microbiology of Institute of Medicine, Tribhuvan University, Nepal. He has completed his MBBS and MD degree, and also he has completed his infectious disease fellowship and clinical research and global clinical research from Harvard Medical School, USA.
Namaste and good morning to all. I am Dr. Ranjit Shah, an infectious disease expert, a background-wise MBBS, MD in microbiology, then infectious disease fellowship, clinical research from Harvard Medical School, and presently a global clinical scholar in research training in Harvard Medical School. So we will today be discussing as on epidemiology and clinical aspect of SARS-CoV-2, that is COVID-19. It will be an overview since I am the first person to begin testing of COVID-19 in Nepal. It will be a great to share a few experiences as well, and as well we will see an overview of the COVID-19 as a whole. So by December 4, there were 65 million people infected. This disease began in back December 2019, and then it is spread all over the world. The case started from the Wuhan and then spread all over the world. We started from very few cases from Wuhan, then it is spread all over the world, and now by December 4, it is more than 65 million people affected all around the world, and which causing more than 1.5 million deaths all around the world. So you can imagine this begin the pandemic, which begins with a few cases in Wuhan, spread all over the world due to the now development of this airways and other resources. Now disease is spread very fast and all over the world because it is this disease is infectious as well. It is mortality is also not so high, but the people which 1.5 million death is not a joke or not cannot be discarded or cannot be taken to the shadow. So this disease is serious. It get in, we people get infected and people also die from this disease. So what scientists wants to know about the coronavirus outbreak? That initially it's began in December 2019. Then around 31 January, the WHO declared it as a public health concern, and on 11th March they declare it as a pandemic. And pandemic means the people in every corner of the world are equally risk to get infected. So that is why on 11th March WHO declared as its pandemic. So what we are talking about? Why this pandemic is so much chaos all around the world? It is a RNA virus that is a SARS-CoV-2 that is responsible for this disease called COVID-19. This is the largest known RNA viral genome. Before coming to the SARS-CoV-2, we have to know that it has been there was a previous version of SARS-CoV-1, or what that is not called one, that is called, I think, coronavirus, that is SARS virus, which was began in 2002 and 2003. And this SARS-CoV-2 is similar to 80 to 85% in their viral genome with the previous one. So it is named as the SARS-CoV-2. Initially, the disease was known as the novel coronavirus because we are not able to give any name, and it was a new virus, so it was named as the novel coronavirus. And then after that, the disease caused by it was termed as the COVID-19, coronavirus disease 19, because it was diagnosed in December 2019. So what we are going to talk about this. This is a previous knowledge on what are the previous knowledge on coronavirus we have. The Wuhan 2019 novel coronavirus outbreak, epidemiology, clinical feature and diagnosis, some of the management, prepared and responses, and implication in the travel around the world, including Latin America, and conclusions. So let's talk about the genetic diversity of the coronavirus. You know, this coronavirus are the RNA virus, and it has a family which includes many, like alpha, beta, delta, and gamma. So this coronavirus SARS-CoV-2 belongs to the beta coronavirus. So genetically diverse coronavirus, you can see all these viruses are usually in the nature. They are have a nature in the host, there is a host like mostly the bat, and then they get to the intermediate host that may be something like camel was in 2013, that was responsible for the MORS. SARS initial part one, the initial version, that is SARS-CoV, that was in the bat, then it goes to the civet cat, and then it spill over to the human. So these are in the nature. They go, there is the primary host, natural host, in which they doesn't cause the disease, but then it goes to the intermediate host when there is a close interface with a human animal interface. Then after this intermediate host goes transmit this viruses to the human, and then responsible for the any outbreak. So this was one article which we published, and we find out that initially in back in February, that what are the many publication on SARS-CoV, SARS coronavirus, and we didn't find many, but nowadays you can find a lot of publication on this coronavirus. So now WHO annually reviewed users priority has been concerned this coronavirus into their role. So let's talk about the origin of this virus. This origin virus, we are not sure till now which is the natural host, from where this virus came, which we are still unaware of it. Because initially, what we are talking about this SARS-CoV-1 in 2002 and 2003, that was from the bat. This virus was in the bat, then it is goes to the civet cat, and then it spill over to the human, and human to human transmission occur. Similar case, there was a MORS, that is the Middle East Respiratory Syndrome virus, that was in the Middle East, and it was again from the bat, and then it goes transmitted to the camel, and from camel it comes to the human. This MORS has the 35% of mortality, and then now our present ongoing pandemic, and that is the again the coronavirus family, and that is we are expecting it is in the bat, and from the bat we are not sure which is the intermediate host, and which intermediate host is responsible for transmission to the human, and then again from that part of we usually you have seen a lot of videos coming from the Wuhan wet market. There is a lot of animal were getting sold, and we are expecting one of them is responsible for transmission of this virus getting from the natural host and becoming an intermediate host and giving to the human. So this is again over a natural spillover. We are not sure where it was. It was in the bat, or it is the where it is. Then it is a natural host, and then from natural host, we are expecting that some of the intermediate hosts were exposed, and that intermediate host with the human in animal interference, that the virus is getting spread to the human and to the all. And now again, this virus is from the human going back to the animals of domestic animal as well. So this is again the same thing. We are expecting that the source of the virus may be a bat or something like a penguin or a snake. We are not sure which is the source of the virus, and that has came to the human being. And from human now, this is again transmission to the local domestic animal, as well as some of the reports were seen in the USA in their zoo. Tiger has also been found to get infected with SARS-CoV-2. So talking about the genome, it is a really a huge, large genome viruses, and it belongs to the beta coronavirus that you have to understand, because we are talking about the coronavirus as a four, that is alpha, beta, gamma, and delta coronavirus. So among that, we are talking about the SARS-CoV-2, and that belongs to the beta coronavirus. Even MERS, SARS-1, these all are from the beta coronavirus family. So it is the same. The you can see here, that is the beta corona alpha coronavirus here, this is the delta, this is the beta coronavirus. And in beta coronavirus you can phylogenetic analysis of SARS-CoV-2 and MERS. So we can see over it is the MERS, SARS-CoV-1, that is SARS virus, and SARS-CoV-2 all belongs to the here into the beta coronavirus family. Again, we are talking about the SARS coronavirus, this SARS-CoV-2, and there are a lot of sequencing published from everywhere, even from Nepal. Also, we have published our first case. We do our sequencing in the Hong Kong, and in Hong Kong, from Hong Kong, then we submitted to the GSID, and from GSID, we have published in Asian Journal. So in the phylogenetic analysis, we are aware now this is the family Coronaviridae, and we are talking about this beta coronavirus, and beta coronavirus, we are talking about this SARS-CoV-2. This is the sequences that was of our first case coronavirus that came up from a student who came from directly from the Wuhan, Wuhan University and to the Nepal. He was get infected. We have collected the sample and done the PCR as well as sequencing, and this is the sequencing which was similar, 99% similar to the virus that was originated from the China. This is from the GSID data, and you can see now there are a lot of variant. There are clades which we got. You have to understand that initially we used to think there is a one type of virus, but there are the mutation all over the world, and there are circulating many clades of the virus. Among that, S clade, L clade, V clade, Z clade, GR clade, GS clade, and other clades. So these all are the clades of virus. This is the different variant of virus which are spreading all over the world, and everywhere this is not the same virus. The mutation has occurred, and there is the different clade of virus. So what we are talking about this virus, how it get entered inside our body. Then mainly it get into the through the respiratory. How it get transmitted? It transmitted from the respiratory secretion, mainly from the respiratory droplets. So what happened when you get contact into the close contact with a person who is already infected with this coronavirus disease, COVID-19. So you get in contact, and if you uh, inhale the respiration, what they have, respiratory secretion that what they have released into the environment, means within a 1 meter of contact, and then you get your virus inside your lungs. In the lungs, they virus what to do? They usually use the ACE receptor from which we get inserted into our body, and then pathogenesis began. So this was little different from the SARS-CoV-2 what we are talking about. That is the MARS virus. MARS virus uses the different, that is DPP4 receptor, whereas the SARS virus are using the angiotensin converting enzyme 2 receptor. That is the point. So this is again the same thing we are talking about, like SARS human, SARS civet, SARS human civet. This is the pandemic. What was been found that we are getting infected, and what was the viruses. So pneumonia outbreak associated with the new corona, probably a bat origin. That was one of the hypotheses. We have not sure it till yet. So let's talking about the COVID-19. We are again discussing the same thing, that SARS-CoV-2 COVID-19 responsible for COVID-19, that is using the AC2 receptor to enter inside our respiratory epithelial cell, and then begins the pathogenesis. What is the difference from SARS-CoV-1 that was in 2002 and MERS, that is the different receptor? Although SARS using the same receptor as the SARS-CoV-2, well as the MERS virus receiving this entering this DPP4 CD26 receptor. And what is the differences? That this MERS virus has high mortality, although this too has the almost similar mortality. So one of the coronavirus that enter inside your cell, after entering inside a cell, there is the ribosome. It injects its genetic material inside our body. Then in ribosome, it goes into the translation. Then replication occurs. Replication, after genomic replication, then again they form this whole viruses, and then it release into the exocytosis occur. So this is one of the pathogenesis when uh, a replication of the virus inside your cell. You can see this is the electron microscopic picture of the Hong Kong University. They have done this cell culture as well, and it studies in detail of how the virus replicates inside our cell. So distribution, we have talked about it. This is the lung tissue, which we can see the changes affected of the effect of this viruses, changes of COVID-19 infection of lung biopsy picture. So there will be the skin changes, there will be the brain changes. Everywhere we can find the evidence of viral infection. So we have also found there are the two kind of thing. There was one is linked to the Wuhan market, and another is not linked to the Wuhan market of the cases that was responsible for outbreak. Means there were a certain type of people who are directly linked to the Wuhan market, and there were certain people who were secondary cases, like to the people who were infected from the Wuhan market and then get infected from there. This is how the outbreak occur and how the outbreak is spread. So talking about the transmission, we have to understand that there are three points that is important. We are not sure about the foodborne or foodborne infection, because since this is the uh, envelope virus, envelope get dissolved by the gastric acid present in our stomach. So this foodborne fecal-oral contact is a little seems to be impossible, but air close contact is a possible, airborne is a possible, ocular surface is a possible, a vertical from mother to child has been found something. Some cases like that have been reported but not established. Blood transfusion, the rate of virus, the present in our blood, it is only less than 1% the virus is have been found. So blood transfusion, if there is organ transplantation of an infected person, that may be responsible, but clear we are not sure. Organ transplantation, again, that there is a huge amount of blood and organ is getting big transplantation is going on. So it may, but we are not so much sure. The most common is the airborne, and then is the ocular surfaces. So you have to, if you are either respiratory secretion is the more responsible for it. Now talking about the aeroplane, you can see that there are a lot of this. All thing happened because people get travel from Wuhan to all over the world. So we are talking about the mainly about the aeroplanes, and you can see that in airplanes there is the flow of the air, and if the close contact air cabin outlet, there is out inlet and outlet, people are sitting together, and if an infected person is there, there is a high chance to get infected of the other as well. So there are certain recommendation while traveling towards the in the aeroplane, and what will be the first thing when you are transmit to the airport, get to the passenger should wear masks, social distancing, self symptom checking, general hygiene measures. If you are a passenger, masks, group boarding, social distancing, general hygiene measure, and SARS-CoV testing. So these are the what you need to do. What is the mitigation strategy need to be performed? If it is the staff, there should be a marks and other things. So this is a very very important slide for people who are traveling abroad, who are trying to travel from the flight. So that what are these mitigation strategy, what are the things they need to follow. This is very very important, and you can find everything like what is for the passenger, what is for the staff, what is with the air crew, everything you need to understand and follow up. MERS and pregnancy, there are 12% women were infected with SARS-CoV-2 during 2002 and 2003 pandemic, the initial one, whereas the 57 were found severe in the first trimester of miscarriage, and 20% women died due to the pregnancy. In similarly, in case of MERS, there was also very much 11%. In review, 11 pregnant women infected with the MERS-CoV-2, MERS coronavirus, that is Middle East Respiratory Syndrome virus. Then 91 presented with the adverse outcome. So MERS was really a severe condition for them. First case of novel coronavirus infection in children in Shanghai. You can see that there is the this is all about the respiratory virus, and that is going to infect the lung. So we know that now bad discovery of bad coronavirus through surveillance and probe captured next generation sequencing. So there are a lot of evidence that is focusing as the bat as a source, natural source of these viruses. What is how we can diagnose it? So first, before going to diagnose, we have to understand how it get transmission, and we'll talk about at the end of the our presentation as well. The most important thing of the spread of the disease is it is getting in spread when we are getting in close contact. So how you can get prevented, you can get prevented by wearing a mask. Then what will be the other option? It can go transmission through the your eyes as well, ocular surface also. So you need a protection of your eye, protection of your respiratory secretion, and hand hygiene. These three things is important. Why hand hygiene is important? Because if you are going to, this virus is again live or survive on the surfaces. So when you touch the surfaces, it comes into your hand, and when you use your hand or come into contact with eye or nose or mouth, then from there it get transmission into your body. So protection of your eye, protection of your nose and mouth, and hand hygiene. This is the very much important thing that how you can prevent yourself from getting infected. So once if it is getting infection, how we can diagnose this disease? The diagnosis of this disease is possible by taking the sample, and the sample is lot of there can be a lot of samples. Like there will be a nasopharyngeal swab, there will be a oropharyngeal swab. Even you can be possible if it is a patient admitted into the hospital, we can take to the hospital. Sputum can be used, even bronchoalveolar lavages can be used, even lung biopsy can be used. So most important and most common sample is now is the nasopharyngeal because it has more sensitivity in comparison to the oropharyngeal. In the initial period of the pandemic, in the initial beginning of the first case in Nepal or in January or February, we used to take only the oropharyngeal sample, and it has the sensitivity of only 35 to 50%. So we came to the conclusion, there was a lot of research, and we found that nasopharyngeal has more sensitivity. It is around 70 to 90%. So we came to practice and using only the nasopharyngeal sample most of the time. In the reality, in the present clinical scenario, if you goes to the patient, now you, since there are two swabs stick into the VTM, we use both sample. We take the nasopharyngeal as well as the oropharyngeal, both sample, and put it into the medium viral transport medium, and then transport to the lab, maintaining the low temperature, that is a cold chain. And when it's entered into the lab, then we process it. We process it by the different. There is the one term. There is a PCR lab where we can do allocating from the BTM. We separate it and create a backup plan. So if we need to do further testing, we can uh, do it. Then from 200 microliter, we process for the PCR. For PCR, it is a step called the extraction. We extract the virus from that sample, and then after extraction, we get it to the master mix room, where master mix the reagent are primer probes and all the enzymes were mixed, and then transferred it in the template room. And from template room, both the master mix preparation and the viruses, that template of the viruses, the dead viruses, the genetic material which we extracted from the viruses is mixed together, and then it is processed finally into the PCR machine, where after, depending upon the company which we are using the reagent, the result will come in 1.5 to 2 hours. So this is how the PCR goes on. So this is how the real, uh, all over the world we are working for PCR. There are the other method also for going diagnosis disease. The most common and frequently used is real-time RT-PCR. Then other according to the reliability and availability and feasibility, sequencing are also be done, and some of the place phylogenetic analysis are done after analyzing the sequencing data. So the differential diagnosis, if a person come from the, like, so what are the symptoms we are talking about? If the symptoms may be a fever, there may be a sore throat, maybe a cough, may have some other symptoms like diarrhea, some have the fatigue since it's a viral diseases. These are the common symptoms. There are maybe other symptoms as well. So if there's such symptoms are coming, we are thinking it may be a SARS coronavirus, it may be MERS, it may be SARS-1, it will be H7N9, influenza virus, hemorrhagic fever, Ebola, bacterial like carbapenem producing enterobacteriaceae, or other meningococcal infection. So this is just a differential diagnosis of a patient coming to us. But since we are dealing with this pandemic, the first diagnosis we think is COVID-19. So it's depend upon the how we can differentiate is depend upon the fever and other other associated feature like fever and toxic appearance. Then we think of dengue, malaria, typhoid. If it is a severe pneumonia and ARDS, we're seeking about the streptococcus, legionella, and other bacterial infection as well. So it's depend what are the other associated symptoms as well. So if we are talking about the coronavirus, there will be the airborne high levels isolation unit is required if there is a aerosol generating procedure. So normally you get protected from the normal marks, but when you are doing a aerosol generating procedure, like you are intubating a patient, then you need a special protection. You need to wear a mask, that N95 masks. You need to wear the special precaution. Then only it will be a possible thing to get prevent yourself. There are a lot of paper published on transmission of COVID-19 infection and from the asymptomatic contact in Germany. There was a paper in the New England Journal of Medicine. So from where we can find out that even asymptomatic people can be also be infectious to other, and that was being proved already. There are incubation period wise, we are finding out the disease has having even 1 to 2 days to 5 to 6 days. So we have a short incubation period, and then the patient develop the symptom. We have to develop symptom. All patient does not develop the symptoms. Most of them are asymptomatic also. So incubation period we can think about 1 to 2 days to 5 to 6 days. So average is 6.5 days, 6.4 days. That is important. So if you are getting exposed and you need to get tested, the ideal time will be a fifth to 6 days. That is the time where you can test yourself. And if you are finding positive, then positive. If you are negative, then you have to understand you have not get infected with that virus. Then we are talking about, okay. So you can see there the disease began from the Wuhan, and it's now spreading all over the world and causing this pandemic. So again, this is the same thing. This was in China from Wuhan market, and then it spread all over the to the neighboring countries first, and then also to the, you can see that was already transmitted to the United States of America, then Saudi Arabia. There was from to Nepal as well, to India, all everywhere that was infected initially, and then we can found that thing important you have to understand is that what is the initial picture. The initial picture, if you can see, that was 31st January, there was only 259 cases death and only around 11,000 people get infected. But today, even it was more than 65 million people getting infected and more than 1.5 million are already dead. So this is what the pandemic is costing us. So now talking about the, you have already know that this WHO has declared it as the emergency committee on novel coronavirus has declared as the outbreak of a public health emergency of international concern. World Organization. Now talking about the declaration in the public health emergency, there are the other viruses as well which has been declared as the public health emergency, and that was the SARS outbreak in 2002 and 2003. 2009, there has been five uh, declaration, that is 2009 H1N1 swine flu pandemic, 2014 polio declaration, 2014 outbreak in Ebola in Western Africa, 2015 and 16 Zika virus epidemic, and 2000s, and as of for the 17th July 2019 there was the Ebola as well. So technique used in diagnosis in virology are like cell culture, antigen detection, nucleic acid detection, electron microscopic, cytology, histology, and serology. So we are talking about what are the options we have. We can do cell culture, we can do antigen detection, that may be do the fluorescence antibody staining, immunoperoxide antibody staining, enzyme immunity, that means ELISA. Nucleic acid detection you can do by PCR and other nucleic acid amplification method. You can directly observe the viruses in electron microscopy. You can see the cytological changes made by the virus in cytology and histology. Even histological, you can use immunochemistry and in situ hybridization. And another is the serological test. So there are a lot of options we have, but most common option what we are using all over the world is PCR. There are other options as well, like RDT, rapid diagnostic test, in which both antibody and antigen has been found, but they are found to be less sensitive. Cell culture is highly sensitive, but it is not available facility all over the world and not recommended as well, because cell culture, we grew the virus, it may be a source of another uh, spread of the disease in that community area. We need a BSL-3 or BSL lab for doing the cell culture. So what would you talking about the sample? Sample will be the most preferred is the nasopharyngeal, because other like a sputum, bowel sample are very difficult to get obtained. We are talking about the ambulatory patient, not the hospitalized patient. Then nasopharyngeal or oropharyngeal swab is fine to get tested for real-time RT-PCR for novel coronavirus. Other sample like serum, urine, and stool are not much recommended. That you have to understand. So transmission, again we have to do transmission at the maintaining the cool temperature, that is 2 to 4 degrees Celsius or 2 to 8 degrees Celsius. So this is about the first line screening. We can do the, what are the tests we can do? We can do e-gene testing, we can do RDRP gene assay, and we can do n-gene assay. These are the three, and there are other as well, like we can do for ORF, we can do for the S gene. There are the many other options which we can test. So what are the proposed diagnostic of algorithm? So what we can do? We can do for the testing for the viruses, that may be a screening test for easing. And after doing the screening test, if it is positive, then we can, it is was the initial point of view. We used to do that. We do the e-gene testing, and if it is positive, then we go for the RDRP and confirm. Was the initial stage in back in the March. So it was in January, February, March. We used to test for using, and then if it comes to be positive, then only we use goes to for the RDRP gene. Now we have other option like ORF gene, we have S gene, we have E gene, we have RDRP gene, we have N gene. So what we do, we now have the lot of companies has make a one single uh, vial, and in that we can found that 2 to 3 gene can be detected at once. And according to WHO, if we have two gene positive, then we can give as a positive. It is a one gene positive, you can repeat the test. If it is consistent, then it is a possible diagnosis, that is presumptive positive. And if it is negative, all negative is negative. If it is more than two gene positive, you can declare it as a positive. So other option you can see, then RT-PCR can be done. Then other is that antibody can be done. Total antibodies can be done. Even RT-PCR is 100% specific. Other are 75%, 50%, 25%. So RT-PCR is the best way to diagnose the disease, that you have to understand. And the timing also you have to understand. RT-PCR initial phase of the life, initial phase of the disease, it will be positive, and then its sensitivity goes down in course of the diseases. So, what are the symptoms of the disease? The most common symptoms are fever, cough, and shortness of breath. Less common is the diarrhea and vomiting. And in advanced case, we found the pneumonia, renal failure, and now there are the other symptoms as well, like they are infecting the others, like brain having neurological symptoms. They are having other symptoms, but the most common are fever, coughing, and shortness of breath. Less few people have demonstrating diarrhea, and another important is loss of the smell, anosmia, and loss of the taste. That is also been found in. Other symptoms include headache and malaise. A high fever is also be found, running nose, then cough and sore throat, muscle pain is there, trouble breathing, pneumonia, sepsis, or even death. So this was the first case which we have found in Nepal, and this was the X-ray of that paper. So now we are talking about timeline. This is very important. The timeline is that we are talking about the timeline of the coronavirus onset, and in that we are finding that this is the onset of the symptoms, and in hospital admission is usually in the seventh day, and then on eighth day we are finding shortness of breath, and there in the ninth day the patient is going into the ARDS, and in 10th or 11th day they goes to the ICU and even into ventilator or death. So you have to understand that initial phase of the study, phase of the disease is not more severe. It is the late phase, that is in the ninth, seventh, eighth, ninth, and 10th day. These are the important time where we get severe diseases and where we are in the risk of death. So these are all the, again, we are talking about the same thing: fever, cough, dyspnea, first day of admission, then are with the respiratory changes and all this thing. So again, this is the one we thinking about. The seventh day is the admission day, eighth day is dyspnea, ninth day is acute respiratory syndrome, and is 10.5 days ICU. And in that 10th, 11th, and 12th day is determinant of your life. You are going to come back to from the diseases, or you are going to deteriorate. So what will be the parameter, biochemical parameter? If you are going to measure a blood and do the lab test, what will be the finding? The finding will be like white blood counts will be normal. They should not going to be a very high and very low. Then will be the neutrophil count, and neutrophil count will be also we can found there is the same thing, but lymphocyte count will be decreased. There will be the lymphopenia, and that is important. The D dimer will be increased. Albumin level, we are not finding much changes, although there will be some. There will be the liver enzyme also changes, but the important thing is you have to understand the lymphocyte count will be less, and there will be another thing that is important is D dimer you have to measure, and LDS, even they are testing for LDS as well. So lactate dehydrogenase is also important to test. So you can find the other this respiratory changes into the CT scan, and CT scan is one of the way to diagnose this disease. Death is found in many patients, and normally ICU patients were finding that 38% are death. So in non-ICU, the recovery is fast. So we need to prevent our patient to getting to the ICU. So before sending there into the ICU, there is need to be take care of our patient. So now coming to COVID-19 compared to the other coronavirus, we have already seen that MERS was killing 34.4% of the people, whereas SARS-CoV SARS virus in 2003 it was killing 9.6%. But our this novel coronavirus is only killing 2% of the people, even less than that. So the mortality, although the people infected is more than comparison to MERS and 2002 SARS, but the death rate as a just because the denominator is so high, the death rate is actually less. But you have to understand one thing very clearly, that death rate may be less, but the people have died more than that of the 2002 and 2012 this virus outbreak. This was the first case which we have diagnosed in Nepal and published in Lancet. So what is now China has changed? This is important actually. China has changed, meaning that when we are talking about this SARS or MERS or SARS, this coronavirus 2, SARS-CoV-2, COVID-19 actually occurs in December, they began in December, but they were able to do the sequencing, diagnose the disease very fast. When you are talking about the SARS in 2002, that was really, it took a lot of time to get developed because at that time we don't have the enough facilities. But at present, they, there was a lot of facilities, the sequencing was easily available, and because the sequencing was available all around the world, it was possible to make a diagnostic tool. And after making the diagnostic tool, look, when we release the sequencing, then after looking at to the sequencing, we prepare the our testing reagent, we prepare the primers, and after making that primer, it was possible to send all over the world for testing. So sequencing is very important, and it was very is early done by China in this outbreak, and that was very important point. And they released in the first week of January, and that was one of the basis for all the diagnostic and research and all of the information that we know now from about the COVID-19. So talking about the algorithm, we can have that asymptomatic patient in contact with the novel coronavirus, then we do the contact tracing, then patient management, and if it is a type of exposure is close contact or causal contact, if it's close contact or causal contact who are developing symptoms, and we test for them, and then accordingly we do isolation of the patient. What are the drug treatment available option for the novel coronavirus? Normally, drug treatment, we have no any clear-cut magic bullet for the treatment of COVID-19. But there are some drugs that has been used and that has been now using for in the clinical practice. And one of the drug is remdesivir. Remdesivir has been used approved by FDA for the emergency authorization for using in COVID-19. But there is a lot of trial going on, and some are saying it is very useful, some are saying it is not useful at all. But you have to remember one thing: remdesivir works in an early phase of the life. If you are giving early phase of the disease, if you are giving the remdesivir in the early phase of the disease, it recovers the patient fast. But if you are giving in the late phase, there is no use of it. Other are the lopinavir, ritonavir, nucleoside analogs, neuraminidase inhibitor like oseltamivir. They have been utilizing. There have been a lot of research is going on this. There was the combination like remdesivir and chloroquine has been, there was a lot of data, a lot of news were come about the chloroquine, but finally that was been, now chloroquine is not used of it. There is the other that steroid has been found to be very effective and they are using it, but this is not a whole treatment. This is the one of the which steroid has its effect and this is found to be useful, but it is not a magic bullet at all, or treatment, complete treatment of it. Regarding the vaccine, there are a lot of vaccine in develop, and we will just get an overview. There are a lot of vaccine we have published about it also. So, if talking about the vaccine, there are the 51 candidate vaccine in the clinical evaluation, and among that, Sinovac, Wuhan Institute of the product. Then there is the from the Pfizer company. There is from the Oxford, that is the AstraZeneca. Then in case of it from India, all over the world, mainly US, that Pfizer company, then UK based Oxford, that AstraZeneca, then China, there are the two vaccine they are releasing. Then coming to the Russian, there are a lot of vaccine that is into the phase 3 trial, and in phase 3 trial, what we are finding that is useful. We are hoping that they will get the emergency authorization from the FDA and WHO send that, looking to the which is the best vaccine available for all over the world, and looking to the feasibility of the price that will be spread all over the people around the world. So these are all the vaccine we can found that has been working, that has been the race to getting permission, that has been in the process of doing all the clinical evaluations. There are 163 vaccine that is in the preclinical evaluation as well. So talking about the marks, there will be the correct way of using the surgical marks. That is important since with this slide is very important actually. We have to understand that When you are talking about the heavy weights droplet and small droplet, if I am getting infected and the disease is getting transmitted, the disease when get transmitted, we have to understand that it will transmit how it will get to the look. If you are infected person, and if you are getting, suppose this is the, you can see over here, there is the happy small floaty droplets, heavy wet droplets. So talking about this is a disease, this is a person which is not infected, where suppose this is the person where we are thinking infected. So look about the size. This is the size of the particle. They are getting drop. Larger sizes get droplet. This is the infected portion. Suppose we are talking about, and there is the largest droplet size that get dropped over within certain meters of time. So why this is important is that mention, you have to maintain the distance. The distance is very important. When if you are in the 1 meter of distance, you have chance of getting COVID-19 very high, because if you are maintaining more than 1 meter, this large droplet will not get up to you and you will not get infected. So distance is, this physical distancing is very important factor for getting prevented from COVID-19, because the droplets what which you are releasing will transmit in the air and that will get dropped down. If you are 2 meter away, then these droplets are not coming to you, and if it is not coming to you, then you will not get infected. Wearing masks is another option. So if the droplets comes to you, then it will get over the surface of the mask and it will not enter inside your into your air which you are taking in. So now, till now, it is a droplet and contract precaution. The airborne isolation, we are not sure till now. There are a lot of publications which saying it is an airborne transmission. Airborne transmission means it can go even up to the 10 meter. So that is not yet confirmed. But till now, we have to think it is a droplet infection. So we should maintain a 2 meter of distance. And contact precaution is important because it also get transmission from the fomites. So when do we airborne? If it is a airborne, it's like if you are into intubation, suction, bronchoscopy, and CPR. At that time, the virus generated R will be released, and it will be fast. At that time, you need to wear the all proper, like N95, PARP, or fitted and CAPR or PARP or fitted N95 marks prior to entering the room. That is very important while you are doing any airborne, any intervention that is going to release the aerosolization of from the patient. The main message is the pandemic is not over yet, and you need to get protected yourself. You need to get prevent yourself, and the best way is to wear masks, maintain physical distancing, and hygiene. This is only the way we can get prevent ourselves from getting infected and break the chain. So the world is facing newly described coronavirus. WHO has declared COVID-19 outbreak as a global health emergency. Transmission can be through zoonotic spillover and human-to-human transmission as well. Transmission through environmental surface need to be studied and confirmed. Early and accurate identification is the most important and critical step in providing early diagnostic, containment, and adequate support treatment in time. So that is all about this COVID-19.